So today we have the opportunity to speak to and talk about nursing in the cancer setting. Lieutenant Mantz is here. Hi, Lieutenant Mantz.
Hello, Darryl. Great to see you.
Great. Can you tell our audience what you do and where you do it?
Yes, absolutely. I'm currently stationed at Fort Belvoir Community Hospital, and I also recently spent time at Walter Reed Hospital here in the National Capital Region. I have served as an inpatient oncology nurse and also as the Survivorship Program coordinator here at Fort Belvoir to take care of our patients who have completed treatment.
And Fort Belvoir is a Navy or Marine facility or some sort of hybrid? What is it?
That's a great question. So actually, Walter Reed and Fort Belvoir are two of the DoD's just straight DoD facilities. It's run by DHA, so we are a true joint facility. Both hospitals are. We currently reside. Fort Belvoir is on an Army base, whereas the Walter Reed facility is on a Navy activity base.
Great. And is it like physically close? Can you jog over from one building to the other?
No, sir. No. So we are at Fort Belvoir, is in Fort Belvoir, Virginia, which is Northern Virginia. We're about 20 miles south of DC, whereas Walter Reed is actually up at Bethesda, Maryland.
Okay, so a long jog, really. So, so I mean, you're a nurse, like in a military base. For civilian patients, like if they were to show up, what would they see that's different aside from your uniform?
That's a great question. I think a lot of it is in the sort of customs of the military. So the way that we address one another, of course, our dress, our uniform. But I think one of the biggest things that patients who are within the military treatment facility system, I think one of the biggest things they would notice is there's not as much talk or concern about insurance and those things. Certainly at some level there is, but what we actually see on the floor and in our nursing practice, it's a really beautiful system because if you're active duty or you are a full retiree, you are covered by TRICARE. And so that sort of encompasses your entire treatment course. Whereas I think at civilian facilities, there's a lot more to sort of figure out in terms of what your insurance will cover. And it's been one of the great joys of being a military nurse at a military treatment facility for those active duty patients, is we can really give them the highest standard of care for regardless of what their diagnosis is.
So since patients don't have to worry about paying for things, in general, outside of perhaps a gift of donuts for the nursing station or something, what are your conversations with patients like? And specifically, what are most men, older men with cancer concerned about?
Gosh, when you're talking about cancer care, it really impacts every piece of your life. And, depending on the type of diagnosis, specifically for prostate cancer, the treatments vary, and depending on what point in your disease progression you're diagnosed, your treatments are really, you have a lot of options. And so I think sort of the biggest concerns is how is it going to impact my daily life? Can I continue with activity levels that I've been continuing with? How is it going to impact my sex life? All of these different concerns for men that have been leading, a very active lifestyle that is characteristic of men who have served in the military.
Yeah. And, most men will complain like, I don't spend enough time or have enough time or am offered enough time with my doctor. The consults, are quick. They're in and out of the hospital rooms. I barely could get a phone call that lasts a few minutes. But I mean, that's a different experience for you and a patient. Is that right?
It really is. It's one of the things that I love most about nursing. We are the patient's advocate. We are your front line. We get so much more time with the patients than the doctors do. At no fault to the doctors, it's just the way the system is set up. What I find a lot of times, especially with the inpatient experience, is the physicians come in first thing in the morning. You're just sort of waking up. They ask you if you have any questions, and you've just been sort of stunned by the information the physician has given you. And the minute that doctor walks out the door, all of the questions that you have come rushing to your head. And so I think the beauty of the nursing patient relationship is having that opportunity to ask the nurse any questions that you have, and potentially questions that you don't necessarily feel comfortable asking a physician, whether you feel like you're wasting their time or it's not something that's within their area of expertise. That's what we're here for. That's what the nurses are there for. And regardless of whether we know the answer right in that moment, or, we have to reach out to other resources, we will answer any questions that you have. And also find resources for you. So particularly with the survivorship program, that is my main goal, is to speak with a patient, find out every little thing that's bothering them in their current life or any concern that they have, and find a suitable resource for them that can really get them the quality of life and sort of the things that they're looking for.
How is your conversation with patients different than a doctor's in terms of expertise and authority and confidence in the information you're sharing?
Yeah, that's a great question. I think the physicians, they provide a lot of information, and they provide sort of the cold hard facts. What are your blood levels? What are your, what's your PSA level? What are the sort of what's the science that's there? And I think the nurses are able to sort of interpret that science into language that helps patients understand how that science is going to impact their life day to day. We're also going to ask a lot more about just the patient's well-being, which seems sort of a little bit more touchy-feely than I think a typical conversation with a doctor would be, because we get down to a lot of details about patients' concerns by finding out how they're feeling about their diagnosis, how they're feeling about the treatment that they're undergoing, and really help to uncover some of those resources that they potentially didn't even know they needed. They might be feeling depressed or these other feelings. And it really might just be fatigue related to the treatment, or possibly they need a referral to behavioral health to discuss some of these sort of different issues that they wouldn't necessarily talk directly with the doctor about.
And why do you think men feel more comfortable with you than speaking with their doctor?
It's a great question, sir. I think the fact that we do spend so much more time with the patient, I can be in a room hanging fluids for a patient, or, even bringing them their breakfast, anything like that. And while I'm in there, I have the opportunity to talk to them about their family, about, what was the last vacation they went on, some of those more personal details that really, I think, build rapport and help us get to know one another. I'm able to share about myself as well. And I think having that back and forth communication helps people feel a little bit more comfortable. I think also we have that added time, and we have the ability to bring up issues that we know are common for different diagnoses. And so being able to sort of bring up those issues in a more conversational manner just creates a safer, more comfortable environment for patients to open up.
Yeah. And when you're doing these conversations, are they actually like scheduled, or it's like the patient's just grabbing you in between bedpans and things like that?
Yeah, never scheduled. Nothing with nursing is ever scheduled, unless, of course, you're coming in for, a treatment in the clinic or something like that. But gosh, those conversations really just, the beauty of it is that they do just really come up whenever there's something relevant, whether, you could be walking into a room and there's a particular TV show on the patient's television, or with military, one of the really kind of great things is you start talking about what other areas they've served in, what was their favorite duty station, where were they born, where did they grow up, what made them want to join the service in the first place. And as you get into those conversations, again, all unscheduled, just sort of impromptu conversations, you really get to know the patient a lot more and help to tailor their treatment and their needs based on their specific experiences.
Yeah. And to the best that military guys and women, but, we're focused on men with prostate cancer and transgender women with prostate cancer. It's more likely that they've been involved in a conflict zone or a life-threatening situation, or have read about in detail about such things than a civilian would. It's more likely that you've been shot at than I've been shot at. Does that sort of inform cancer health and cancer decisions and the way somebody lays in bed waiting for surgery or recovering from surgery?
I can't really speak to the experience of the patient, but what I can say and what I've observed is we have patients who have served overseas, who have been deployed, who have just had these intense experiences that you're speaking of. And I think a lot of times they are very hard on themselves when it comes to cancer treatment and sort of the feelings of fatigue and fear that are associated with cancer. Because I think that in their mind, it's this thought of, well, I have been shot at. I have gone through all of these more challenging experiences and sort of more dangerous experiences. And so they sort of belittle the cancer experience in a way. And I think that cancer is very scary. And I think in a lot of ways it's scarier than being shot at because there's so much unknown. But a lot of guys think, well, I got through this, I can get through this as well. And they can absolutely get through it. But I think that they need to sort of take advantage of the resources that are out there.
Yeah. And as you were speaking, it occurred to me, I've been shot at. I've worked in conflict zones doing refugee resettlement stuff. And, the event is very time limited. It happens, and then you spend the next day or two just sort of shaking it out. With cancer, you're laying in bed, and that's the rest of your life once you're diagnosed. So I could see how it's a bit different. There's also the sense that I don't really have any experience with, but the sense of how does an individual's cancer relate to the camaraderie of both the people that the patient works with, as well as their friends and family. Do you see dynamics around that? I don't want to let my squad members or the men underneath me and women underneath me down, by being in this bed with the cancer diagnosis.
Absolutely. We see a lot of that. And one of the ways that I think we see that is, patients will be undergoing chemotherapy inpatient in the hospital with their laptop on their lap, continuing to work. And I think just that work ethic and that idea of not wanting to let their fellow, soldiers, sailors, airmen down is definitely present. I think one of the upsides of that we see is the community of whether they're active duty or retired, the community of survivors and those undergoing treatment is really strong within the military facility. We'd have, for a lot of our active duty patients, we'll have survivors come in and they'll come in their uniform, they're still on active duty, and show folks that they can get through this treatment and they can come out on the other side with a quality of life that is as good as, or sometimes better than what they went in with. But in terms of just the way that it is impacting, I think again, for active duty folks, we see a lot of fear that their people will be med boarded out. So as soon as you get a diagnosis, they think that means you're sort of, going to get kicked out of the military. And that's definitely not always the case. And I think there is some relation to that, even if you're retired, and sort of our men that have served and gone on to live their next retired life. I think it's similar in that way. A lot of our retirees that we have come in for treatment, they're now working at the Pentagon, or they're working in some other GS job, and it's all the same. There's still that camaraderie, and there's still that fear that they're letting their colleagues down.
Yeah, and just for people like me and others who don't have a clue what GS means, what's that?
Government service. So a lot of coming in back into the workforce and to a federal agency as a government service employee.
Cool. So there's also concern that's unique. What I imagine a concern unique to active duty and retired guys and transgender women, around exposure that civilian folks may experience, but don't sort of relate to in the same way that military folks do. What are some of your conversations with patients around that?
So do you mean environmental exposure?
Yeah, toxic materials, depleted uranium, tipped ordnance, jet fuel, inhaling it in a helicopter, things like that.
Yeah. So I think, we definitely have some of our retired patients who come in and they may have been exposed to Agent Orange or, some of these other toxins. And so I think there is that sort of benefit in terms of the military knowing what those exposures were and sort of identifying on a larger scale patients who may have been exposed to those things. We have younger folks come in who were exposed to burn pits and some of those other, theater areas. And it's a lot. I think that we see more and more here at, Belvoir and at Walter Reed. We have really robust occupational health programs. And I know there is a lot more focus on that in the military than maybe there was years and years ago. But I think there definitely is that concern for folks that are coming in from overseas, like what, led to them being diagnosed. And unfortunately, a lot of times we don't know, except in the cases of, like those individuals who are exposed to Agent Orange or other identified agents.
Yeah. Let's talk a bit about the survivorship program you've mentioned. What is it, and, why should we bother with it?
Absolutely. So we recently received accreditation as a cancer center here at Fort Belvoir. Part of that, one of the standards is to have an established survivorship program. And survivorship is intended to provide sort of a transition of care from your oncology team back to your primary care team. So it's specifically here at Belvoir right now, the program is intended for patients who were treated with curative intent and have completed their treatment. And so essentially that they are in remission. And the point of the program, the point of the meetings is really to make sure that patients understand their surveillance schedule now that they have completed treatment, and also to make sure that they have all of the resources that they want. So for instance, we complete an assessment of a complete review of systems to check in on any evidence of cardiac toxicity, any issues with lymphedema, issues related to behavioral health, concerns related to sexual health. We really want to make sure that that patient is living the quality of life that they want to lead, and that they have access to resources to live a healthy lifestyle. So we can link them up with our nutrition professionals. We can also ensure that they are set up with, exercise programs. We know that really physical activity is such an important part of cancer prevention and also remaining in remission. We also know that fatigue is one of the most common side effects of your cancer treatment. And a lot of folks who are in that survivorship period really find that it takes them a while to get their energy back up. And we want to make sure that they know that sitting on the couch is not the remedy for fatigue, that it really getting up and getting moving is actually the cure for fatigue. We also make sure that a big part of it that I mentioned is their surveillance. So if you talk to any survivor out there and ask them what their number one concern is, I think you'll find a lot of times it's fear over their cancer returning or getting another type of cancer. We know that a lot of the medications, a lot of the chemotherapy drugs that we give can actually cause other types of cancer down the line. We know that they're necessary at the time to sort of get rid of the cancer that is currently impacting them, but we know there's risks associated with those medications. And so it's very important that these patients follow the recommendations that their providers are giving in terms of getting labs completed, getting clinical exams, getting their CT scans, or any of these other things that their providers are putting them on a schedule for. They really need to take care of those surveillance appointments.
Yeah, and this program, or actually, let's jump out of the program for a second. How do you work with family members and friends of the soldier or sailor, or Marine or whoever it is, that the patient, what's your role as a nurse with people who are visiting?
Yeah, that's a great question. I think especially during the inpatient experience. So pre-COVID, when we were allowing sort of any visitors in to see patients, you are really taking care of that full family. And that's really a philosophy that guides nursing practice, that it's family-centered care, patient-centered care, and really understanding that the patient is part of a system, right? The patient is part of a family system, and the health of that system is going to determine the health of that patient. So specifically, again, during the inpatient experience, another one of the beauties of sort of military nursing is that for instance, if you have a patient who's from Idaho, but they've been admitted to Walter Reed, we actually have ways to get their family to be there with them at Walter Reed. We can put them up in the Fisher House on base so that they have really easy access to come back and forth and visit the patients. I know at Walter Reed specifically, all of our HEMONC rooms were set up with a couch that had like a pull-out sofa, an area for the patients' families to sleep and really stay by their side. So absolutely, you are there 100% to provide information, to provide moral support, to provide comfort for not just the patient, but also their families.
That's great. Tell me a story of a time where you felt the best thing you could do was to hold the patient's hand.
Yeah, absolutely. Gosh, there's so many. I think, I had a patient, it's been about 2 years now, who was in sort of an advanced stage of their disease progression and didn't feel like they could express in words in real time to their spouse how grateful they were for everything their spouse provided for them and the attention that they gave them and just the care that they had, the life that they had shared with them over the years. And I think in those instances, as a nurse, you are there just to hold their hand. And in that case, it was holding their hand with one hand and writing a letter for them with the other hand. And having the patient tell me exactly what they wanted to say to their spouse, and being able to write that letter and hand it off to their spouse to make sure that they were represented the way that they wanted to be. I think that's one of the experiences that will always stay with me. There's so many. I mean, our patients are incredible. The patients that we see are just unbelievably strong. And I think that's one of the experiences that will always stay with me.
Yeah. And finally, like around that sort of theme, do you think that post-traumatic stress disorder among nurses, the day-to-day job of nursing is less spoken about, less understood than it should be?
I do. I think we deal with a lot of what we call burnout. And I think one of the good things is a lot of healthcare facilities, ours included, are really focusing on what we call resiliency. So the ability to have an experience like that, that I just spoke about, and still be able to go home and live your life to sort of the fullest without always carrying around that sort of survivor's guilt. It's difficult. I think a lot of facilities are recognizing the difficulty and also are seeing the turnover in areas that are particularly impacted by a lot of burnout. And so they are, planning activities and offering services at Walter Reed on the HEMONC unit. We actually had a tranquility room, and they had zero gravity chairs. We had Reiki practitioners coming through for the nurses, not just for the patients. I think the trouble is, getting nurses pulled away from their patients long enough to take advantage of those services sometimes. But I think it's definitely been overlooked, but I do believe it's improving.
Yeah. And, I don't want to take away from the seriousness of this moment, but you mentioned zero gravity chairs, and obviously that's sort of like, what?
Yeah, they're these great, it honestly looks like a fancy lawn chair, but it's it completely reclines back and puts you in a position where you feel like you are in kind of one of those float tanks or one of the zero gravity chambers, and allows you to kind of disconnect and just feel light after all the heaviness that we deal with.
Great. Well, Lieutenant, I hope you have many opportunities to feel light after the extraordinary work that you do and the great care that you offer to your patients. And thanks for being with us today.
Thank you so much, sir.
Okay, bye.
Bye.